All right, I think you can start. Welcome everyone, welcome in our next Care Pathway Masterclass. Today we invited Svin Deneckere from KU Leuven. So Svin did his PhD and investigated the impact of care pathways on interprofessional teamworks. And the results were published in the scientific journal Medical Care, and they were quite impressive, and that's why we invited Svin. So they showcase that care pathways are an effective and workable intervention to improve teamwork, management of conflicts, and organization of care in teams. And in addition, care pathways also reduce the risk of burnout among caregivers. So in this webinar, Svin will walk us through how to build high-performing teams using care pathway. What impact do care pathways have on outcomes, and how do care pathways promote interprofessional teamwork? The masterclass is recorded, so you can download and watch it at any time. And if you have any questions, feel free to just put them in the chat, and Svin is more than happy to answer them throughout his talk. So the floor is yours, Svin. We are all ears.
Okay, thank you for the invitation. Maybe just for the practical, I cannot see other attendees. I can only see myself. Is that normal?
Yeah, that's because it's a webinar indeed.
Okay, sorry. So I have to talk against the screen. Okay, welcome at this webinar. I realize now that it's been a while since I presented in English, so I try my best, and bear with me if it's a little bit unclear sometimes. And ask questions indeed if you have, if there are unclarities or questions during the presentation, we can look at that for sure. Indeed, this is work that of a PhD study that I performed on care pathways and teamwork, and the relation between both. This work is from since 2013, but is still important, and I think it may be even more important than it used to be. I will take you through a short presentation where I will look at well, the importance of teamwork, then what care pathways can do to improve the teamwork, and then go through the results of the study itself and the conclusions. Okay, so if we look at, first look at why teamwork in healthcare. One of the jury members in my PhD study, Eduardo Salas from the United States, said, cited this, patient care is a team sport. However, healthcare is in this unique that in no other team sport, there's a greater potential for catastrophic outcomes. We actually see that, firstly, there's a staggering rate of change in knowledge and in medical knowledge. There's an increase in specialization of healthcare professionals, and there's an increasing social interdependence. What does this mean? It means that, it implies that if we want to reach a high quality of care, we are more dependent on each other as team members, as multidisciplinary team members, to achieve that quality of care. As an individual profession, you can have an impact on quality of care, but that effect will be influenced by other team members, by other professional groups, by other individuals. So we need each other to achieve a high quality of care, and that is more than it used to be. We also see that there's still a problem of patient safety in hospitals, and in the healthcare, where we see that about 10% of patients hospitalized are harmed by the care they received. And we see that although these studies, the first studies are from 2000 and 1998 to 2000, we see that earlier studies confirm these results and even emphasize these results. We also saw that if we look at what are factors that influence these results, then we see that poor communication among team members and poor coordination among team members and among teams was a contributing factor in almost 2/3 of these adverse events. So improving communication and coordination was identified by the World Health Organization on patient safety as priority number 1 for improving patient safety research in developed countries. In non-developed countries, there are other priorities than in these developed countries. Okay, so we need to work more as a team in healthcare. We know that for a while, but these results confirm this growing need for teamwork in healthcare. If we actually look at teams in healthcare and we compare this to other teams in other sectors, in other contexts, and we look at what to define real effective high-performing teams, then we can only say, and Michael West was one of the other jury members in my PhD, we can say that we actually are not really working with teams in healthcare. We are working with pseudo-teams, what is called pseudo-teams. We think that we work with teams, but if we look at what is a high-performing team, what are effective teams, then we can only say, and this is not, of course, this is not black or white, it's somewhere in between, but we cannot say that we are really working with high-effective, high-performing teams. Why? That is why, if you can see some of the characteristics of pseudo-teams and some of the characteristics of real teams, we see that in healthcare, team members largely work on their own, with little requirements to interact or communicate with each other. The objectives within the teams are unclear, are unknown, are not shared. And these team members rarely meet with each other. I emphasize that this research is on multidisciplinary teams involved in care processes for patients. This is not on a nursing team working on one ward. This is on multidisciplinary teams who are together responsible for the care and the quality of care for a group of patients involved in the same care process. And we see that these team members not only do not share the objectives as necessary, but also rarely meet and rarely exchange information on performance, on how do we actually, what are our standards, what are our results, how can we improve those results, and what is needed to further improve quality of care. So in this, this research concluded that we are actually working on pseudo-teams in healthcare. Now, why is that? And if we compare the healthcare sector with other sectors, why is that so obvious, apparent in healthcare? There are several reasons, which if I would ask you, I'm sure you can identify some of these reasons and maybe all of the reasons, because we know why. One of it is that we are working in fragmented, disconnected silos, disconnected organizational structures who all work separately from each other in a good way, in an efficient, effective way. But the problem is that that care process for that group of patients goes through these horizontally through these vertical organizational structures, through these silos. Another reason, which you also know, is that we do not have the correct, not all the correct incentives in the financing systems to promote collaboration, to promote teamwork. Think of, for example, more financing, not based on only performance, but on care processes itself. If we look at the healthcare sector and look on quality, then we also can agree or can see that there's actually a low level of agreement on what is good care, on what is high quality of care that is necessary for this group of patients. And there's also a lack or a low level of predictability. There's a lot of factors, patient factors, context factors, team factors, that can influence the actual result that we get with the patient care, with the care that we deliver. There's also typically in healthcare a high need for specialization, a high interdependence, as already stated, and also a high functional diversity. This leads also to higher interprofessional boundaries, so boundaries between professions that are all working for the same patients and patient groups. And there are different educational backgrounds. So we rarely meet with each other during the education and also in the daily practice following. Also looking at other sectors and in healthcare, there are more power and status differences than in other sectors. There is also a large, high competitive power, and thus these status differences, which will influence the way that we work with each other in a multidisciplinary team. And there's also an unclear leadership structures. And for example, in my PhD research on all the teams that participated in all the different countries, one of the questions was, who is your team leader? And from the same teams, from the same hospitals, within the same hospitals, we got different answers on that. So this means that there are unclear structures on leadership within these teams, within the healthcare teams. And then for the last, we are working in temporary ad hoc teams with low group identity. We do not identify as being part of the multidisciplinary team, or not enough as to the multidisciplinary team responsible for that group of patients. No, we probably identify as being part of the nursing team, or probably as being part of the team of orthopedic surgeons or others, but we do not see us as being a part of the group, the multidisciplinary group responsible for that group of patients. There's a lack of role clarity, who does what at what time and is responsible for what. And we are poorly trained, poorly trained on technical individual professional skills, but poorly trained as being a high effective, high performing team. And also we see increasing job demands, high workload, and different work schedules, which again influence how do we work with each other.
Svin, we received a question from Vanessa. She asked, can you please share some examples on how to finance healthcare to promote collaboration? Do you have an example?
Yeah, well, for example, if you look at the literature on the value-based healthcare, which of course you will know, you have this package financing systems, where you not only finance the prestaties, the performance. The performance is made by an individual profession or an individual medical doctor, for example, but you finance the whole package of the total care process for for the chronic condition, for example.
Yes. So it's the shift from fee for service to bundle payments.
Yes, yes. I was looking for the term bundle payment, but yes.
No worries. No, great example. I totally agree.
Yeah. Okay. Okay. So if we look at another example of this professional fragmentation that we see more in healthcare than in other sectors, this implies that this patient, with his own needs and expectations, is lost in this Bermuda Triangle, where we see fragmentation on different levels. We see fragmentation, and these are all positive. These can all be positive, but the interaction between these different types of fragmentation implies that the patient is lost, that the vision on the patient is lost. We see more and more decentralization to more responsibility on the teams within the care processes itself, which is of course a good evolution. We see more and more professionalization of the professional groups delivering care, and we see more and more specialization. And these three factors influence each other and increase this professional fragmentation, which again influences the way we work with each other. If we look then, for example, at the patient safety literature and the impact of teams, where do these safety incidents occur? This is on where these teams, where different teams meet with each other. One team can work perfectly with each other within, for example, the nursing team or within the team within the hospital. But the actual incidents, accidents, adverse events are, the risk of adverse events are higher at the moment that these teams meet, where they do not actually interact and coordinate with each other. If we then look at the literature on how to become a high-performing team, then you have, well, different types, again, of working groups, which do not have the necessity to actually work with each other to improve their results that they get. A working group is a group of people which share information, best practices, help each other, and they get a rather good results. Here in these working groups, it's not necessary to interact with each other. But what we've learned is that in healthcare, this necessity of this task interdependence is way higher than in other sectors. So we need to work as in teams. And we see that we work in these pseudo teams. So actually our results are worse than in different types of working groups, because we have this necessity to collectively perform together. What we can do, that Katzenbach says, to increase this performance is to try and improve our own overall performance by clarifying our purpose, our objectives, our goals, improve our products, our processes. And if we do that, then we can go through potential teams and real teams. We can grow as teams if we work on our objectives, on our goals, on our processes, on our relations. And then what defines if we can move through high-performing teams? That is time. The longer that we work with each other, the more we can grow as a team. Sorry. So we can learn from that also in healthcare sector. If we now look at how can we improve teams, and how, then there are three types of interventions, team interventions. One type is teamwork training programs, and we see that in healthcare, in the healthcare sector, these type of team training initiatives are more and more used. For example, crew resource management, cross-training initiatives, team building exercises, not only on relations, but are really on improving these goals, objectives, and working with each other and rehearse our interactions. these are things that are also already used in healthcare. Then we see another type of intervention is on structured protocols, briefings, checks, the surgical safety checklist, for example, or SBAR methods, which protocols that want to improve communication between different teams, team members, individuals, IT tools, of course, for example. This is also some intervention that can improve this teamwork. But what we are focusing on with care pathways is the final type and the last type of, and these are organizational interventions. Interventions that seek to change work processes, not only specific tasks, but the whole complex interactions within the care process and the structure that they support for achieving a better, more effective communication and cooperation. So what we are trying to do with care pathways is actually, as I mentioned, to improve this matrix organization, where we see that there's vertical silos which are disconnected with each other, and departments, professional organizations within these hospitals, in this case, that also work largely separate from each other. With care pathways, we try to improve these connections, improve this care process that goes through these organizations and departments. So we focus on this patient process. And now if we look at what is a team, then we can see, and what is a care pathway, we see some similarities. If we look at what is a team, then a team is a small number of people with complementary skills who are committed to a common purpose, performance goals, and approach for which they hold themselves mutually accountable. This is the definition of a team. So some important aspects are mentioned. If we look at the definition of care pathways, then also we can see it's a complex intervention for the mutual decision making. So it's of organizing care processes. So it's focused for a well-defined group of patients during a well-defined period in time. And then some characteristics: we are searching for goals, we are searching for to improve communication, coordination, documentation, and this by identifying and improving the appropriate resources. So we see some similarities between what is a team and what is a care pathway. And then we, of course, are interested in investigating what is the relation between teams and care pathways. We also know that building care pathways is a team effort, and that we have to do this development of care pathway by using, for example, the PDSA or PDCA cycle. So it's not an individual task; it's always a team task and a continuous process of improvement. Now, if we look at, for example, the development of a care pathway in this example for hip fracture, we see that this is a multidisciplinary effort, and we see that we also try to improve this care process for this type of patients. If we look at teamwork and team improvement, then we can use this GRPI model of team improvement, which says that if you want to improve the team, and if we look back at the Katzenbach model for achieving high performance teams, then the first thing we need to do is to look at our goals, our objectives, and take care that these goals and objectives are shared and are clear for all our team members. So the first step is identifying these goals. Now, what can these goals be? These can be team goals, communication goals, but these are mostly, because we are working with care processes, goals, key interventions that we want to implement for this type of patients. For example, for hip fracture patients, this is for an actual good, if the hip fracture patient enters the emergency room, the goal is then to, as quick as possible, examine the patient and examine the medical history of the patient. Another goal is to, as soon as possible operate the patient. We see that how earlier you operate, the better the results you achieve. And then, of course, is to educate the patient, to prevent falls, to prevent pressure sores, to manage and cognitive status and delirium, to as early as possible mobilize the patient, to check and manage fluid and nutrition balance, and to have an adequate discharge management. So these interventions, which are called key interventions, these interventions that have an actual impact on the quality of care for these patients, are your team goals in care pathway development. The next step is to identify, if these are my goals, who do I need to achieve those goals? Which disciplines, who within my team do I need? And then you can see, well, this large multidisciplinary group of professionals that we need to actually deliver the results on the goals that we want to achieve. So, for example, if you want to improve, or if you want to improve mobilization of your patients, you, of course, will need the physio within your team. If you want to improve nutrition balance, then you will need, and this is an actual very important goal for this type of patients, then you will need a dietitian in your team, and so on. Social worker, if you want an adequate discharge management, then you will need this team. So you define your roles, and you define the roles that these type of professionals have in your care process. So the next step is then to try to improve role clarity, task clarity, who does what, when, in which manner in your care process, and then in your care pathway development. And then the last step, by doing this process, this PDSA cycle also, you will find that you can improve interprofessional relations within your team, and of course then also the results that you achieve as a team. So it's a stepwise approach which you can use to improve your team by using care pathways. Okay, this is also, if you look at the care pathway development process, then you will notice, and people that are involved in will know that it can be very positive at the start of the process, but you will find some factors that will influence during your results during the development. So it's not so easy to develop care pathways. And if we look at what a care pathway is, if for this team, then we can compare, for example, with a music score. Each individual itself can be a professional artist and has the perfect technical skills within that team. But the problem becomes is that there is no, in this example, a music score, that there's a music score needed to perform wonderful music. And the pathway document and the IT tool itself can be the tool you need to improve this team performance. If we now look at the results of our objective of our study, then we had two main objectives. One was to evaluate the impact of care pathways on interprofessional teams. The second objective was to build knowledge on which active components of care pathways are factors that influence the effect of care pathways, not only on teamwork, but also on actual quality of care. We had some hypotheses. The hypothesis was that, of course, there can be an effect of a care pathway implementation on patient indicators, on quality of care. But our hypothesis was that this impact of a care pathway on patient outcomes is mediated by teamwork. Okay? So teamwork is a mediator for the implementation of your care pathway. So more effective teamwork can improve the effect care pathways have on patient outcomes. This was the triangular relation which we hypothesized in our study. And thus, of course, the first question is then, is there actual an impact of care pathways on teams? And then you can look at the triangular results also. We performed a study on this, a clustered randomized control trial. Cluster randomized control trial because we could not, because this is an organizational intervention, we could not randomize patients into an intervention group which developed a care pathway and into a control group which did not develop a care pathway. You cannot randomize patients in these two groups. No, you have to randomize organizations, teams, because it's an organizational intervention. So we invited teams, both for hip fracture and for chronic obstructive pulmonary disease, COPD, teams to participate. We randomized them into an intervention group and into a control group. We guided the intervention teams in developing a care pathway during 1 year of study. And we asked, the only thing we asked at the control group was to do not develop a care pathway during the study period. And then, of course, we followed up the implementation process within our intervention group. And at the end of the study, at the end of the implementation of the care pathway, we asked or we identified some team indicators and measured some indicators on teamwork between as well the intervention teams as the control teams. You can see some indicators, team indicators that we used. We also have a study on that if you're interested on which indicators you can measure to measure team performance. And then we looked at the results. If we now look at the results, then of course, and Rick also referred to this publication in medical care, then we found some apparent results. Teams that developed the care pathway, so that were in the intervention groups and that were scored on team indicators, and then compared to control teams that did not develop a care pathway during that period, these teams perceive themselves after this intervention as being more, perceive themselves more as being a real team. So they identified, they had a higher group identity by developing care pathway. They also identified a better conflict management. And you can imagine, or if there are people who are in this call that already developed the care pathway, you need good conflict management skills if you want to develop a care pathway. But we also see that if you go through this phase of care pathway development, that your skills are improved on conflict management as one of the indicators of good team performance. We also saw a higher climate for innovation after care pathway development, and a higher shared vision and objectives and task orientation. Task orientation, this concept is related to what we saw on the third or fourth slide on team reflexivity. How do we as a team look at our performance, relate to each other, talk about our performance and try to improve our performance. We did not find significant differences in leadership qualities. This is also not something that you target when you develop a care pathway. And we also, what we did expect it, but we did not identify significant differences in coordination, relational coordination. That's a concept itself. That is also, this is the communication skills and coordination skills within the team. So we did not find significant differences on that. But most important results is that we found better organized processes, not only on coordination, communication, but also on follow-up of the care. We identified improved level of organization of care. And the most important results of the study, we found a lower emotional exhaustion within the teams that developed the care pathway, and a higher level of competence as scored by the team members in the teams that developed the care pathway. And these two are classic factors that impact the risk of burnout. So we found a significant positive result on these factors, and we then identified an almost half percentage of risk for burnout in these teams that developed a care pathway. Now, if we look at the elements that influenced care pathway implementation, it's also an interest for you. I think we used the normalization process model. We looked at endogenous and exogenous factors. We looked at how does the implementation of the care pathway affect interactions due to this is a research on, this is qualitative research. Then we looked at the integration and how the social networks around the care processes related with the existing relations. We looked at which skills do you need as a team and as a to be working with care pathways, and we looked at the context. Which context do you need? And these were the results. This is I will send you the presentation, of course. These are the results on these 4 factors within the normalization process model, and identify these factors you need if you want to work with care pathways. And if I will not look at all of them, but we made some conclusion. If we look at these implications of our research for care pathway development, then we look at these factors, then we can conclude that, well, as care pathway facilitator, so the person that is responsible for the development itself, you always should analyze the specific, not only the process itself or the patient goals, but also the organizational and team context in which you are working, and how you can improve that. You also, based on the analysis, an effective implementation strategy and protocol is needed if you want to improve. Then you have to follow up your implementation process. This is also very important. And you need, of course, a supportive leadership and an active team involvement. This is also very apparent. And then you need some conflict management skills and a willingness for change in this care pathway development process. Staff should not only be trained on technical skills, but also on non-technical skills. So we have to evaluate, or we should evaluate that we need additional team training components in care pathway development processes. And we also need to make a teamwork needs analysis. What does the team need to perform actually as a team if we want to improve care pathway implementation? We of course need the engagement of staff. We need maybe the last one is also important. If we develop one care pathway, this can work in our typical hospital organizational structure. If we develop 5, 10, 20 and more care pathways, then we will probably, and we want to be effective again, then we will have to change our organizational structure. We will have to move through from these disconnected structures to this service line driven organizational structures in which the patient process is the defining factor for your organizational model. So we need to move from this typical hierarchy matrix structures to this service line driven organizational models. And this is what we also saw in other literature, for example, on clinical microsystems, quality by design by Nelson and Batalden and Godfrey, where we found that what we are doing with care pathways is actually building these clinical microsystems and linking these microsystems, these teams, working within units, and linking these teams within these units with each other. So if conclusion is also that care pathways should not only be used to improve care processes and patient goals, but should also be used to design teams and organizations. So that's the main conclusion of our research. And if we look now at the research itself is 7 years ago. If we look at the years that we had now, we see a second or another important factor than the team factors is of course the patient factors. Where we are not only interested in indicators, quality indicators that are relevant to the team, but are also and more interested in improving these indicators that matter most to the patients. And this is of course the prompt and premise. And we are now in care pathway development are actively involving patients also in this development process, where we use experience-based co-design approaches to not only to develop care pathways, not only by the team, but also by the patients. Okay, that's the most important things that I wanted to share of our research with you.
Thank you. We received a question. Do you also saw an impact on patient outcomes with your research or not?
We saw, maybe I'll stop by sharing the screen. Well, maybe I will wait. Yes, so there were several PhD studies in this big project, and my PhD study only looked at the impact of care pathways on team work, but there were other PhD studies who also looked at, is there then an effect on patient outcomes? And we did define some results and some important results, and which are also published. I can also send these publications on both COPD indicators and also hip fracture, mostly on process indicators. I don't think that we found real results on outcome indicators. And of course, well, we need to think about how to further also improve this effect on these outcome indicators.
Thank you. Does someone else has any questions? I don't see any questions coming in, Svin. Thank you so much for your time. It was very interesting, and we will share the present. Can we share the presentation with the attendees as well?
Yes, of course. Yeah.
All right. I will share the presentation with everyone that joined or did not join. And we just received a question from Fabrice as well. Do you think care pathways can be deployed in Europe with no model of payment? I think she means that we don't have a bundle payment system at the moment.
Yes, that's of course, and that's what I also said on that's the same for the organizational structures. If you want to develop and implement one care pathway, then maybe it will work within the current organizational structures and with the current financial systems that we use. But if we want to make care pathway development as a model for our healthcare organization in total, and if you more and more develop care pathways, then you not only will need different organizational structures, but also different financial incentives and structures. So, and again, a bundle payment together with some performance financing, which also still has some important results and contribution, but it will be a mix of financing systems that you will need to actually gain from the full effect of care pathways.
Yeah. And she asked a follow-up question. Can we consider a care pathway a digital therapy with reimbursement?
well, it's how does it? Well, if we look at care pathways for now the 20 and more years that we are investigating and developing care pathways in Europe, I think the first developments of care pathways in Flanders are from 1998. I was involved from 2006, and then a care pathway was a document, was a matrix, a time task matrix. If you look now at the care pathway is not a document anymore, but it's an IT structure, an IT tool. And I know, of course, that AWEL is very involved in this evolution. So yes, we can. Care pathways are now more integrated into patient records, into patient IT systems, and these also help on how to improve the actual implementation of care pathways.
Yes, correct. We also received a question from Brahim. Have you involved in the team the administrative managers who are at the strategic top, or did you went bottom up or top down?
You cannot develop a care pathway without involving the top of your organization, but it starts at the bottom. It starts at the care process itself, and this is if I refer to the clinical microsystems approach and the book and the literature on the quality by design. This is the most important message out of this clinical microsystems approach. If you want to improve quality, you have to start there where this quality is made. I hope I can make myself clear. You have to start at the building blocks of the quality process, and these are the building blocks in the care process, and that's the same for care pathway development. But of course, you will have to look also at the context and the structures. So yes, in these in the organizations that had the most effect on the actual quality of care, there's also, you can also see that there were the most involvement of the actual top of the organization. Yes. But you have to start at the care process itself.
Interesting. And Klaas asked the question, does a team leader needs to be a doctor or a medical skilled person?
A medical skilled person, yes. A doctor, in most cases, also. So there's a difference between, there could be a difference between the team leader of the care pathway development and then what we call the care pathway facilitator in the team, where the care pathway facilitator can be someone of staff, quality management staff, but the team leader should be the actual medical doctor, not always the medical doctor, but who has the actual knowledge and skills and competencies, technical competencies, medical competencies within the team itself. That's also a recommendation within our research.
Klaas, as the follow-up question, what's the biggest benefit for high-performing teams in healthcare? I'm not totally sure what he meant with that.
I'm not sure either. But the biggest benefits is that you have that you receive a better quality of care. I think if that's maybe the easiest answer. Yes. Because you see that there's a clear relationship between the way that you work as a team together and the results that you get as a team. So there's a clear relationship not only between teamwork and patient outcomes.
Yes, and then we received a question. I don't know if you have any more time left, Svin.
Yeah, I have some minutes. Yeah.
She asked, what about, Monica asked, what about participation from patients and families when designing care pathways?
Yeah, we see, and again, I refer to the 20 and more years that we experience that we have with implementing care pathways. This is also something that you that we saw an evolution and an important evolution. And at the start, patient participation in care pathway development was about informing patients. That was patient participation, informing patients on the care pathway itself when it was developed. During the evolution on care pathway development, we saw the necessity of patient participation and to have more emphasis on patient participation. So they did not only became someone to inform, but they became an actual team member on developing the care pathways itself as experts themselves. I refer to, again, the evolution on, for example, experience-based co-design, where you design the process with the patients themselves.
Yeah, and then Mika asked also a question, what about teams and sub-teams? So you mentioned a dietitian for nutrition, then you also need to involve the ENT. So I think that's, what is it called again? Ear, nose, throat, and then SLP is probably speak language pathology, are indispensable in this too. So how do you define the teams and the sub-teams, and how much people do you need to involve?
Well, that's of course is defined by the pathway itself, by the process itself. So what you need to do there is when you start with your care pathway development team, and then you have defined what is your care process that for which you want to implement a pathway, and what does this, where does it start and where does it end, this care pathway, and then also define what are my most important objectives that I need based on, of course, evidence-based literature for the patient groups. What are my most important objectives that I need to affect? Then you can look at, and you know these objectives, then you can look at who will I need to improve these objectives in. So that's what I mentioned before. If you want to implement the care pathway, for example, for hip fracture or something, and you do not relate to the physiotherapist, well, then you will not be able to build an effective care pathway. Or if you know, for example, for hip fracture patients, that there's an important effect also. These are more elderly patients that also have nutritional problems and etc. Then you will need to also implement and relate to the dietitian and the geriatrician, and you have to improve the relationship between the surgeons and the geriatricians and other. So it's dependent on the process itself.
Yes, and then I think we have the last question. So what value would you ideally adhere to the various steps, and how do you calculate that value?
Will you actually repeat?
Yes, so what value would you ideally adhere to the various steps, and how to calculate that value? I think Miki means that how can you calculate or prove the value you bring with a care pathway, and the impact on the team itself?
I do not get the question.
Miki, can you maybe clarify the question a bit in the chat if you're still here?
Well, if you look, maybe I can. If you look at team performance, team performance is also you have to look at a multi-factor system. You need to evaluate team performance as a multi-factor system. If you want to improve, which means that if you want to improve team performance, then you not only have to look at communication, for example, or not only on conflict management, or not only on coordination or improving some skills, but you need to look at the inputs, the processes, and the outputs of the team. So we need to also look at the system approach to improve. And this is what we also saw in our research, that the performance of the team is not only influenced by the factors within that team, but also within the context and structure in which the team is working. And if you want to look at the effect of a team, you not only need to look at the processes, but also at the structures and at the outputs of that team. And there are different types of indicators that you can use to evaluate team performance. I hope this is more clear.
Yes. So Fabrice answered as well that besides the teamwork processes that you just described, that patient outcomes is also something very important to show the value
of course, yeah.
care pathway.
That's the first one. That's the most important goal.
Yeah, indeed.
Do not forget that that all we do is with care pathways is trying to improve patient outcomes. What our hypothesis and what we proved is that you can improve the effect or the effect of care pathways on patient outcomes by building effective teams.
Yeah. Mika clarified as well that she has difficulties to calculate KPIs for SLP, so it's speech language pathology, because there are little objective measures and very few prompts. Do you have any suggestions or things she can do?
Well, not really on speech language processes. I would. There's, of course, I do not know how many percentage of the of all medical interventions are actually proven by evidence-based literature. I do not know if you can make an estimate of that. It's a question. Well, maybe our answer it's almost 20 to 30% of all medical intervention are actually proven by evidence-based high impact studies, evidence-based literature. So this means that if you want to look at outcomes, at indicators, you do not only need to look at literature reviews, systematic literature reviews, meta-analysis, but you also need to look at the expertise of the team itself. So you need the expertise of the team itself. So that's why you need to involve that team, and you can define patient outcomes, team outcomes, process outcomes that you want to improve. Maybe that's an answer. Yes, evidence-based is different than practice-based evidence. Yes, that's true.
Yeah, and what we do with AWEL when we collect proms and prems is we first see if there is an outcome standard set, but I don't think there is one for NLP or SLP, sorry. And what we then do if there is no outcome set is like what Svin said is we sit together with the team and ask like what are the KPIs that matter most to them. And then we also have some patient interviews and family interviews, and then we define KPIs together with them. So that's also something that works for us. All right. I don't see any other questions coming in, and we are a bit over time. Thank you so much, Svin. I saw a lot of comments from people stating that it was very, very interesting, and I do agree with all of them. So thank you for your time, and we will send the presentation and the recording of the session this week once the recording is finalized.
Okay, perfect. Thank you.
Have a nice day.
Bye.